The Birth Circle podcast features experts in all the nuanced areas of pregnancy, birth, and postpartum with the aim of helping women make the choices that will keep them safe, healthy, and empowered. We respect all birth choices and believe in supporting informed consent and evidence-based practices. Nothing said on this podcast should be taken as medical advice. You should always seek the advice of a competent professional for your care. Welcome to the Birth Circle podcast.
This is Sarah with Birth Circle, and today I have Dr. Nicole Rankins with me. And Nicole is an OBGYN physician and certified integrative health coach. And she's also the host of the All About Birth and Pregnancy podcast, which is great. You should head over there and listen to it. And the creator of the birth preparation course. Thank you for joining me today.
Thank you so much for having me.
So tell me how you got your start. What was your interest? Because the life of an OB is definitely not the most smooth profession you could pick.
Yeah, so I've been in practice for almost 15 years, actually. I can't believe I graduated from medical school 18 years ago.
That's really a long time ago. You're like an adult doctor, like your degree is 18 years old.
It is indeed. It is indeed. So I initially started out doing research and thinking I was going to have a career in research and academic medicine. That was not the right sort of best fit for me. So I did that for a few years and then kind of stumbled upon being an OB hospitalist. And what I do now as an OB hospitalist, which is what I've done for the past, almost 5 years, I guess, maybe a little bit longer, 5-6 years. I just work in the hospital. So 99% of what I do is help bring babies into this world, and I absolutely love it. So I do shift work actually in the hospital. So I work 24-hour shifts at a time, and I do 7 of those roughly a month, and I deliver babies. And then, so that's like my quote unquote day job, but it's also a day night job.
Wait, so you only work 7 days in the month, but they're 24-hour shifts.
Correct. Yeah.
Oh my goodness.
Yeah. I mean, most of the time I get at least some sleep. There are times when I'm up the whole time, but most of the time I usually can
There's
get
a nap somewhere,
yeah,
in the
somewhere.
back closet somewhere.
Yeah,
I mean, I just
yes.
have this like fascination with the life of an OB, like how you guys handle, because there's a lot of discussion about how that system is not great because women don't have continuity of care. They don't know who's going to be at the birth. It's hard for them. But on the other hand, it's so hard for birth providers to be on call
Right.
all the time. So at least you
Right.
get it out of the way, right?
Yeah. Yeah. And it works. I mean, I think it works both ways. It actually has some benefits to it. Obviously for me, it works. I have a predictable schedule, a flexibility. I have time to spend with my family, but for the birthing person, it actually has been shown a hospitalist model to help decrease the cesarean birth rate because we don't have a rush. There's no impetus for us to rush birth at all. And there's no like 5 o'clock C-section because the doctor is trying to get home or anything like that.
Because you get to go home no matter what, and your replacement deals with whatever comes.
Right. So we're there. We're going to do whatever we need to do for that period of time. So it definitely decreases the cesarean birth rate. And I think people who are attracted to hospitalist medicine, that's one of the things that you know that you have to do is being able to establish rapport quickly with patients and help put them at ease, even though I'm meeting them for the first time.
Yeah, I was going to say that was my next question is how do you make that? I'm not familiar with the word hospitalist. What is the actual definition?
Yeah, so that just means all I do is work in the hospital. And as an OB hospitalist, there's also like internal medicine hospitalists, so in different specialties. So that's just a generic term for a physician or a provider, really. It could be a physician's assistant, could be a midwife. I actually work side by side with midwife hospitalists who only work in the hospital. So it just means you only work in the hospital.
Got it. So you don't do any outside births or
don't do any outpatient. I don't see patients for prenatal care, postpartum care, for any gynecology care.
Oh, okay. There's the niche. So you're not actually seeing them in their prenatal care. So the first
Nope.
time they meet you is with their legs open. So
well, not quite, but the first time they meet me is in the hospital. Yes.
Got it. Okay. I mean, the first time I met one of my OBs was at the stitching level.
Right.
So yeah.
Okay. Yeah. So
Like, hello,
it
sir.
is,
Nice to meet you.
yeah. So it is definitely,
Yeah. That wow, I can
I meet
see
them
that.
only in the hospital.
So what is some of the things that your team tries to do to make the continuity feel safe for the woman?
Well, I think the way obstetrics is being practiced in general anyway, there's not that many providers. Some still do. That it's a very high chance, and especially in group practices, that you're not necessarily that the doctor who you meet is going to be another member of the group, of the practice, that kind of thing. So that's fairly common these days. So we're just considered an extension of the practices who we work with at the hospital. So it works out nicely. And like I said, we're able to establish rapport quickly. I have patients not infrequently ask me, can they come see me in the office?
I was gonna say you're so fun already. We've been podcasting for 5 minutes. I'm already in love with you. Please deliver all my future babies, grandchildren. So I could see
So
that. Yeah.
yeah. So that's my day job and day slash night job. And then on the also I actually went back and got additional training. I did my residency training at Duke, and then I went back there to become trained as a certified integrative health coach. It was a way to sort of help women like really make changes in their health beyond just like go on a deeper level and a more
Yeah.
holistic approach to helping.
And it's probably like more preventative and maintenance
Correct.
and
Yeah.
self-care
Yeah.
and not like, oh no, acute care.
Right. Yeah. So, but coaching has its own, it's certainly valuable, but it has its challenges, and kind of thinking of a way for me to marry the things that I learned with this holistic approach to health coaching with my job of being an OB. I ended up starting this podcast and creating this online childbirth education class. So that is where I am now.
So you are totally on the education. You love education. You think education is the best. So tell
Very
me
much.
about how education,
Mm.
prenatal education, can help with the birth experience.
Yeah. So the hospital birth system, and I focus on hospital birth. I don't have anything against birth center birth or home birth. It's appropriate for many women and appropriate candidates for it. It's just I don't know that. So what I know is birth
Yeah.
in the hospital, and it's what most women actually do. So I will give that caveat that
Yep.
I
I love it.
focus, yeah, specifically on hospital birth. And hospital birth in this country, and I focus again on hospital birth in the US because that's what I know,
Yeah.
is founded on a system that's based with, misogyny, taking away control from women and the decisions, them being able to make decisions about what happens in their bodies, and racism. And that, we've gotten better. It kind of started really bad where we used to sort of knock women out in twilight sleep, although the origins of that are kind of interesting, where women actually wanted that anesthesia, and then it kind of got
You know
pushed.
what? If you're
Yeah.
up for a little tiny tangent, I would love more information about that.
Yeah.
Because there's
So
so many misconceptions about what it was for, how it's used. And you just said yourself, women wanted it at that time.
yeah, apparently, and a lot of this I learned from reading Rebecca Decker's book. She's with Evidence Based Birth.
Mm-hmm.
She talks about this in her book, Babies Are Not Pizza. And
They're born, not delivered.
yes, yes. And it talks about how women actually wanted anesthesia in childbirth because for most women, they interpret contractions and labor as pain. So they wanted to have access to adequate anesthesia. So there was like an article written and like a push for it, and women kind of demanded it. And then it got to be more frequent. But then when you actually look at how it happened, it's kind of horrifying in a way to watch
Mm-hmm.
and see what it does to women during birth. But actually, some of the origins of it, women wanted it. But some of that, like lack of control, sort of persisted. And then there were things like forceps deliveries and without consent, and routine
Yeah.
episiotomy without consent. And that, don't get me wrong, we have gotten better, but we
Mm-hmm.
still have a ways to go. So things show up today in terms of how we need to work on the way we provide labor and birth. Things like consent for vaginal exams, breaking water, stripping membranes, those kinds of things, and discussions about Pitocin, instilling fear in birth when it really doesn't need to be there. You know, your baby's going to die if you don't start Pitocin, kind of foolishness like
Yeah.
that. So that's kind of where we are. And the reason education is so important is that you need to have information. You obviously you can't be at the same level I'm at in terms of, I've done this for 15 years and I've been a long time. You know, I've went through 4 years of medical school, 4 years of OBGYN training. But what I've done is I've distilled down information to the things that I believe are most important and present just the evidence and the data. I present research and facts, and you can come to your own decisions about what you think is best for yourself. But you need to have some basic information so you are ready to have an intelligent discussion about things. You know, and for so long, what kind of goes along with that is that medicine and physicians have been gatekeepers of information. We had all the books and the knowledge. That has changed.
Yeah.
With Google, there's lots of tons of
But
information out
a lot
there.
of providers don't like Dr. Google. How do you feel about Dr. Google?
Dr. Google is good for some things, bad for other things, and it's a starting point. It's not an ending point. So it shouldn't be that you go to Google and you get to look for an answer to a question. It should be, hey, I found this on Google or on this website. Can we talk about it so I can help so I can take this information and apply it to my own unique situation? So that's what I help women do, is understand things, basic understanding of things, of how pregnancy, labor, birth, so that they can have some baseline information to be an informed participant in their care.
And that being informed is part of the educational process. If you
100%,
don't know
yeah.
what you want, even
You don't know what you want, you don't know what you don't know, or questions that you should be asking. That if when you don't know those things, and sometimes things happen and you don't understand why, or you don't realize until later, like, wait a minute, I actually had a choice in that. Like,
yeah.
yes, you do.
So I can already tell you're a very kind and respectful provider. I'm sure you're not doing the things against a woman's consent, but tell me the difference between, I mean, you could probably peg an educated birthing person over an educated birthing person pretty fast, right? As soon as you
Oh
meet
yeah,
them.
for the most part. Yeah, some people are like, I have no idea, I have no clue,
Yeah.
about things.
Well, in the
And
circumstance, but how do you notice, how does that change their birth outcomes? How does it make you, do you practice differently with the ones that are uneducated versus the ones that come prepared?
no, I mean, I give people all, it's just that if they come prepared, sometimes the discussion is not sometimes, the discussion is just easier to have. And I think we can get through things a little bit faster. If people don't have any baseline information at all, then it may take me longer to explain things.
Which is super fun when you're having contractions.
Or the key is that I'm willing to spend the time to do it, whereas not all providers are. So ideally, if you come armed with some basic information, then you can kind of get to those discussions and come to things a little bit faster. And then the other thing I teach women is how, not just what information you need to know, but how to have these discussions, because there's a little bit of, I think, culture in the birth world, I guess, for lack of a better way, that it's this like, you got to fight and you got to go in and you got to be ready to demand stuff. And it has to be like this contentious sort of relationship. And that's actually the absolute worst energy that you want
Yeah,
around your pregnancy or birth, is one of fighting,
totally.
of one of feeling like you're on your guard,
Well,
you're
here's the
on
thing.
stance. Mhm.
We had to do that in the 80s and the 90s
Right,
and a
right,
little bit in the 2000s.
right.
So, but now it's like that's so 1980s. Thank
And
you for the midwives that went to jail for us in the 1980s. But now, like, there isn't so much of a fight.
yeah, and sometimes there is, and sometimes you do have to get to the fight, but you don't need to start at the fight.
Yeah,
I
I love
think
it.
yeah, so these days you need to,
Yeah.
you can start from a place of trying to connect with people on a human level. And, this is what I'm trying to know, this is what I'm trying to understand, these are the things that are important to me. And then you connect on that human level. If people aren't responding to you on that level. Ideally during pregnancy, you find another provider. You can do that up
Yeah.
until the last day. But
Ooh,
then
ooh,
if
say
Mhm.
that again. You can do
Yes,
it up till the
you
last
can get a new
day.
provider up until the last day. I've had stories, women come on my podcast where they have fired the doctor mid delivery. So they're like,
Really?
yes. So
Wow.
it is possible that you can find a new person,
And
but
even if you're in the hospital and you can demand that a nurse leave, you can demand that an OB leave, right? You
yeah,
can.
you
But like you
can.
said, don't come in with your fists up ready for a fight. But if you
Right.
find
Yeah. If
the
you
need
find
to
you
draw that boundary.
Exactly. So you start from a place of kindness, connecting on a human level. Then if people aren't listening to you, you have to escalate it, of
Can I
course.
just ask you a weird question? Um, how does that affect how you're paid as a doctor if you get fired before the delivery or during the delivery? Or
Oh,
like,
I
how
don't
does it work with the insurance? I'm
um
just curious if
yeah,
that.
I don't think it'll affect. I mean, that's a complicated system the way
Mm,
OB gets reimbursed. It's a global fee where the insurance company reimburses for one fee for the entire pregnancy. So that's kind of may get broken up depending on how the practice structure works. Some of the doctors, whoever saw you during prenatal care, may get part of it. Whoever did the delivery may get part of it. So that's kind of complicated. But in general, someone will probably still get paid even if they're fired.
yeah. Okay. So it doesn't really. It shouldn't play. You shouldn't worry about that. Because I
No.
mean, I know it sounds crazy, but I've had women because a lot of times we're people pleasers. We want to make sure everybody's set, even though we're the ones going through birth. We want to make sure the doctor's taken care of and the nurse.
Yeah, and I think that that's a natural thing, and especially like you
Mm-hmm.
said for women. But don't worry about that, and actually don't think. I think this is a sort of a harsh reality, but at the end of the day, the doctor probably won't think twice necessarily that you didn't come back, or people see so many patients and things kind of go through it unless it's like a really contentious sort of thing, then it just doesn't
They're not
end
going to
up.
take it personally, even
No.
though you're a hormonal ball of,
Right. Yeah.
yeah,
No,
baby.
they
But
don't.
okay, I
Yeah.
love it. Okay, so do you think that a prenatal education is accessible to everyone? Or do you think that there are some discrepancies in how women are able to access that information and how it affects their births?
Sure. So there's definitely lots of free information out there. I think podcasts are starting to be a tremendous free source of information. I mean, I provide a ton of free content on my podcast, but
Mm-hmm.
at the same time, people who are in the birth space, whether it's doulas or childbirth educators, they deserve to be compensated for their work. So, rightfully so, they need to, they need to make money for their work, however that happens. So you'll find varying levels of how things cost and how expensive they are. So there are, yes, some financial barriers to getting education, but I think you can get a ton of information for free. A lot of the benefit of childbirth education is maybe more in contact with a person where you have more access to get questions answered, or you can or the information is nice and organized and packaged, and
Yeah,
so
that's
you don't have to
you kind of
spend
get
so
what you
much
pay
time.
for.
Yeah, so you don't have to spend so much time looking at
Yeah.
things. Mhm.
So you mentioned when we were talking about twilight sleep about pain management, that women back
Mhm.
then wanted the pain management, and now we don't want twilight sleep. That may have just been, the old way of doing things before the better epidurals came in, right?
Mhm.
But what do you think? Are we just more enlightened that we can like endure the pain better, or we can manage the pain better? What what are your thoughts on women that go in with the thought like pain is scary, avoid it at all costs?
I that is perfectly reasonable. So I don't have any thoughts that women should. Sorry, my headphones are falling out a little bit here. Um, I don't have any thoughts that women should manage pain any particular way. That's not the way I approach it. It should be what is it that this individual woman wants, and how can we support her in that? So I don't think women should have like an irrational sense of pain, like it's going to kill them, I'm going to die or anything.
Well, I mean,
right.
it feels like that sometimes, and there's a fear. But then there's also the people that say, well, if you're just not afraid of it, it won't hurt.
Right. Yeah. And
That's
it's
not true either all the time.
Exactly. So labor pain is different. It's limited. We know that it's going to end. We know that on the other side of it is this beautiful thing. You're going to have a baby. So it's a time limited sort of thing. It's probably different than any other pain that we experience in our life or any other situation. But there's some people who I do like to encourage women, like, you don't necessarily, you can be scared of it, but you don't have to like let that fear overcome you, and you can educate yourself about it. But if you want to come in, I have had women ask for an epidural. One of my most funny stories is like, she called and she's like, I'm on the way, and can you get my epidural ready for when I get there? And it's like, well, that's not exactly how it works. But so some women don't want to experience any pain. Some women, like, for example, in the setting of labor induction, even before labor induction starts, they want to get an epidural. And it's
that is a great point, because even if you plan on an epidural, you don't get an epidural at 1 centimeter. So there's still some,
or you can actually, you can if you want. Yes. Like we can't hold these things from women. There's no like rationale behind it. Like,
no, in general we can't, but there are going to be hospital policies, or there's going to be doctors that refuse to.
I think for sure in the past, yes. And there may be, especially doctors maybe who have been in practice longer and have those sort of what are considered pretty, fairly antiquated ideas. But even these days, when you're at hospital, we've learned, or we're getting educated even from our specialty societies, that we don't withhold things from women like that. We don't get to make that choice for them. So
I love that. That's your quote. That's your meme of the day. We don't hold things. We don't withhold pain management from women. So you're saying basically that that's an antiquated approach to say you have to get to 4 centimeters. You have to have an established labor pattern before we'll give you an epidural, because it'll slow down, because that's not true.
Correct. I mean, it will slow down labor, but the studies show, I did a research fellowship, so I'm always about data and research. An epidural will slow down labor by at the most 30 minutes.
Oh, well then. So you can go in there with your fresh manicure and your makeup and get your induction and your epidural and just make it a party.
If that's what you want to do. Or if you want to not get an epidural, then that's what you want to do.
Yeah, sure. For sure. Well, I love your take. It's the same as mine. It's just anything you want is great. Whatever you want is great. It's all.
So we have to try to meet women where they are and put each person, put them at the center of their birth experience, and then go from there.
Put them at the center of their birth experience. Mm-hmm. What a concept. Wow. Okay. So, what about, what's the best way to make a birth plan? So you've got this prenatal education, and then what impact does a birth plan have?
I have a whole free 1-hour class on how to make a birth plan. And so folks can go check that out on my website, which is ncrcoaching.com, although it's getting ready to change to drnicolerankins.com. But the basic things are that it is more than a template, a checklist. Like that is not a birth plan. That's a template or a checklist. It's not a template. It's not a checklist. It's actually a way for you to put the things that you want for your birth into a document, and you need to discuss it during your prenatal visit. The first time that anyone sees your birth plan, and actually I say birth wishes because no one can plan birth. Your doctor can't plan birth. You can't. Yeah,
I like that.
Yeah. You can't plan birth. Your doctor can't plan birth, even though they try to say, well, we can induce you. The only person who has control of the birth is the baby. And we don't know what buttons and levers they hit in there to make things happen. So,
all right, geek out with me on a little bit on that. What are the levers?
We don't know. Yeah. We don't know what starts.
Is it true that the baby starts labor with a hormone coming from its lungs?
We don't know that
No.
we don't know. We don't know
Okay.
what's
We don't know.
if we knew what started labor, somebody would put that in a bottle and sell it, or
Right.
sell it in general, because everybody
Well,
wants to know when is my labor going to start?
or is it just because it's women's health that we haven't studied it in depth?
I think actually it's been studied
Is it been?
fairly. Yeah, I think so, to try to figure out like what starts labor. But whoever figures that out will probably win a
Yeah.
Nobel Prize in medicine or something. But
That would be
it's
amazing.
yeah,
All
so
the
it's
women out there that are 42 plus weeks. Just kidding.
exactly. So as far as the birth plan, it's really, or birth wishes, it's a way to, you need to go through and think about the things that you want, and then talk about it during your prenatal visit to make sure your provider is on the same page. Make sure the things that you want are in line with your own individual risk. For example, if you have hypertension in pregnancy, or there are issues with your baby's growth, then probably intermittent monitoring, where we're not, is not the right
Right.
option for you, because your baby may be at more risk for things happening during the course of labor and birth. So the birth plan is about asking questions to understand how your provider practices, and then formalizing those things in a piece of paper. So that last one page thing is the last step. It's really should be an ongoing kind of touch bases couple times, ask these questions, get these things in order to make it so honestly, the goal would be that you don't need a birth plan eventually, right?
Yeah.
Because you've already discussed everything, you feel comfortable, you don't have to write it down. But it does help to kind of solidify things. And then also the process of making a birth plan is doing it in a way so that the people who are going to receive it, because some people you may not know will actually pay attention to it. So
Yeah, that's true. So what happens though if you've gone over your birth plan with your prenatal care provider, but then they
Mhm.
meet you first time in the hospital? Is that
That's why, you do still need to like have it there. So, but one of the questions that I tell people to ask is, well, who could be there at my birth, and how did they practice in comparison to you? And is there anybody who
because you work in a team, and the ones that do prenatals, you know them, right?
you know them? Yeah. So is there anyone who I should avoid? Can I, think about ways that, who's going to be supportive? Is it possible for me to just get scheduled with you or work with you? Or can you come in for my delivery? Then you can have those kind of questions, and then you can be prepared just in case. And then in the instance where everybody seems, is good from the group. I've definitely worked with plenty of groups where all the doctors are fine. They're all, there's no issues. You still have the page written so you can give it to your nurse, give it to your physician, and you have it done in a way so that people actually pay attention to it.
So what are the most important components on that birth plan? It certainly can't be like what's in your water bottle or what color socks you wear. I mean, what
Yeah,
are
no,
some of the
exactly.
some of the stuff I've seen birth plans that are just like out of control. There's 40 points on it. But what are
Yeah.
like the most key points that you would want to include?
Sure. So if you have some specific preferences about around pain management, then definitely include
Ooh,
that. Yeah. So if you want to do an unmedicated birth, if you don't want to be asked about pain medicine, then put that on there. If you want access to hydrotherapy, like shower or bath, then you want to have that there. But you should know if you have access to those options
yeah.
before you get to the
I
hospital.
demand hydrotherapy. There's
Uh,
no
there's
yeah,
no
there's no
tub
tub in
here.
it.
Yeah.
Mhm.
So definitely ask, those type of things. If you want delayed cord clamping and skin to skin contact, you should say those specifically. We're getting better when we do that more
Yeah,
routinely, but not everybody does still.
right. Yeah.
So you should specify that. You don't so much need to put things that'll happen after the birth. For instance, like if you don't want your male to be circumcised, that doesn't necessarily need to go in your birth wishes,
No,
because
because
you
they
could,
talk to you.
yeah, they'll talk to you about that. So that isn't necessarily anything that's there. So I would say pain management for sure. If you have a specific, and some of this you can communicate, but it may remind you to communicate that you want like dim lights in the room, or you want music played, those kinds of how you want the environment of the room. That's like a one sentence thing. It doesn't have to
Yeah.
be anything particularly complicated. And then really, I usually say, like, put something up there that says the most important thing is for my baby and I to be healthy. Because for whatever reason, especially in traditional medicine, we have this warped view that if a woman has a birth plan, that somehow she's willing to sacrifice her life or her child's life to achieve some idealized
You're
version
not
of birth.
wrong.
And
Yep.
but that's not like, there's
No.
no woman who wants,
Again, it's not the 1980s. We're not,
yeah, right.
martyrs.
So no one wants to everyone wants their baby to be healthy, but I think sometimes when providers hear women say that, it like reminds them, like, okay, yes, like this is the thing that she
Yeah, it's
wants
not
that's
a
most
demand,
important.
it's a preference.
Right, exactly. Yeah.
So
Yeah.
so with that then, that would be one of the ways you could get your doctor to actually pay attention to your plan is by
Yes,
using words like that.
exactly. Yes. And
What
starting it off
what
like
are
that. Yes.
ways
Mhm.
to make it so your doctor won't listen to your plan or like will totally disregard it?
If it's more than one page.
Oh, okay. If it has colored doodles, if
Yeah,
you
yeah.
put it on a poster board, just kidding.
Yes.
No, seriously, what are some other ways?
Yeah, if it's very long, then no one's gonna read it. If it's accept like it's a ton of detail and things that, like, you don't have to put like, I want Stevie Wonder played for the like, you don't have to put all
Yeah.
the some of those things that you can kind of do yourself.
So maybe
Then
take the Cliff Notes version of your birth prep and make it a birth plan and don't
yes.
indulge the entire team
Yeah,
in all of your
it
thought processes.
doesn't have to be everything. I
Got it.
actually like, if you Google visual birth plans, I think those are kind of nice, with the
Ooh.
symbols on them that you can use in order to communicate the things fairly quickly and easily that are most important to you.
And then
So
you tape it to your chest. Is that the best way?
I, honestly, this is the part you just have to say, here are my birth wishes. Can we
Yeah.
talk about it? Yeah.
Yeah. Okay.
Yeah.
Well, I'm just joking about it because there's so much fear surrounding birth plans will even be listened to. Oh yeah, it will be listened to, but then it's not, and then the women are traumatized
Right.
because it's not listened to. So I'm just like trying to get to the best way
Hmm.
to approach it because it's like the best way. Sometimes it's hard to like pinpoint the nuance of why something works and when it doesn't. Like
Sure, sure. Another good way to have your birth wishes paid attention to is to have someone with you who can help advocate for
I love
you,
that.
like a doula. So,
Okay, that
uh,
brings me to my next question. How do
mhm.
you plan? How do you recommend women plan to adapt their plan in the light of what COVID's done to hospital policy and everything?
Sure. So we're starting to come around. Every place is different. I think the biggest thing is you can't have as many visitors. So if you were planning to have like your mom and your
Everyone.
sister and your a partner and a doula, that's not going to happen. It's going to be one, maybe two people. So plan to have like that one main support person with you, and you may be able to have a second one. So like right now at the hospital where I practice, there can be one main support person plus a doula if they want
Yay!
that. Yeah.
Hallelujah!
So plan to have like that one person plus a support person. If you only have that one person, then you may need to, and you want additional support, then you need to investigate virtual options.
Hmm.
So you need to have, like, if you want to have a nice big, like an iPad or something, you need to have long cords so you can plug it in, put things on a stand so you're not like holding it, that kind of thing. So you have to investigate virtual
Hmm.
options, which I've heard a lot of people say have been working.
Yeah,
They're
yeah.
they're
I
not
know a lot of
perfect,
doulas.
but
Yeah, I
mhm.
know a lot of doulas that hate and like it.
Yeah,
Yeah,
exactly.
some doulas can even support multiple people at the same time because it's virtual. They're just, you know,
Oh, that's a
tuning
okay.
in. Yeah.
Right, right, right.
So I know, but I just know like we've kind of taught people that partners are key and a doula is an accent to that, and then you take away that and it's like, what does the partner do? Huh?
Right,
What
right.
are they lost? So you also mentioned earlier the effect of racism in the birth world, and I just wanted
Mhm.
to know what your exact thoughts were on that.
Um, I mean, our whole medical system is our whole society is affected by racism, but we know that some of the adverse pregnancy outcomes and neonatal outcomes and infant outcomes are uh, resulting from racism, and women experiencing, in particular, I mean, Black women experiencing chronic stress and what's considered or something called weathering, constantly under these little micro attacks of things. And uh, it's a complex interaction of how our society, so the things that you're experiencing in the
Yeah.
background in society, how that affects how you are in pregnancy. I think this is sort of anecdotal, but one of the most like interesting things to me, like my friends, and I have a group of friends and we're all physicians, all Black women, all highly educated. Like two had preeclampsia that was pretty bad.
Mm.
Three of us had preterm babies. One, I think the three or four of us had C-section. So just those things that you realize, like how we are affected by things you never know. So one of the biggest things that we've talked, or we hear a lot about, of course, is maternal mortality, where Black women are 3 to 4 more times likely to die related to pregnancy issues than white women. And of course, racism plays a role in that. And a lot of what people don't realize is 60% of maternal mortality actually happens after birth. So it's really important that you know some of the things that are warning signs to look out for. When you read some of the stories that you see, a lot of times it's women who were getting in trouble in those first few weeks after birth, and either they were dismissed or their
Mm-hmm.
concerns were ignored, and they
So,
weren't.
so talk about what is 60% of deaths actually occur after birth. How long
Mhm.
after birth? What's kind of the cutoff before
Most
you're
of
like
them,
out of the woods?
yeah, most of them are within the first six of those 60%. Most are within the first 6 to 8 weeks. And then actually, it can be up until a year, it's
Up until a year,
considered.
but you would think 8 weeks you're out of the woods, but you're not.
Right. Not
Yeah, you're
necessarily. Yeah,
still.
exactly.
So,
Yeah.
what are some of those danger warning signs?
Yeah. So some things you want to look out for, obviously heavy bleeding. That should start to taper off as you go along. So heavy bleeding, if you're having lots of swelling in your legs and it's not going away, not getting better, if you're feeling very, very tired and you're not you can barely like get up, move around, you're feeling short of breath, that's also a
Oh,
concern.
what's a short of breath? What's that?
Yeah, so where you're just like you can't quite catch your breath, and like
Is it like a
even.
symptom of something
Oh, yes,
particular?
sorry. So, yes, so a lot of the issues that happen are cardiac or heart issues.
Oh,
Mhm.
so
Yeah,
people
so
are dying of heart attacks after
mm,
they give birth?
or heart attack is not, because heart attack it's different. It's not like some heart attacks are from blocking blood flow to the heart. Often it's just that the heart is weaker and it gets weak, weak, weak
Isn't it
until.
stronger because it had so much more blood to pump during
Mhm.
pregnancy?
Yeah.
And
Mhm.
then is it like a
Mhm.
deflated balloon and you have water? I mean,
Essentially,
talk to the
yeah.
lay people
Right.
here.
And
So your heart's
or
just having a hard time adapting to normal life. Is that what it
exactly.
is? Oh,
Yeah,
interesting.
yes, it's not common, but it does. And actually I should say, although it's 3 to 4 times as likely, it's not a common occurrence that women die after birth, but it's higher than it needs to be
Well,
because.
but
Mhm.
but all the time when it happens, it's always like, oh, we didn't see this coming, and
Mhm.
or they say, oh, she didn't feel good, but when we took her in and they sent her home, that
Right.
kind of thing, like that.
Exactly.
You're
Yeah.
all ready to you're expected to feel kind of crummy in those
Mhm.
newborn in
Mhm.
that fourth trimester, right?
Right.
So
Right.
how do you draw the line between feeling crummy and like a very serious health complication?
Right, right. Or the other thing that people experience is trouble with blood pressure postpartum and getting blood pressure under control, and then potentially having a stroke from issues related to blood pressure. So the fine line is that we as medical providers should listen to women, really hear what they're saying, and then make that assessment about whether or not things need to be escalated. But the problem is we're not always listening. That's part of
Yeah.
this. Like the CDC has a new campaign called Hear Me. It's here. I'm blanking on what the exact name of it is, but it basically says that it it's language and things that women can use in order to get their provider to hear what they're
Oh,
saying.
wow. And how
Mhm.
many things, how many complications can you kind of self-diagnose? I mean, you know when you feel crummy, but when you're past the point of feeling crummy and you're just in survival mode, sometimes you can't
Mhm.
self-diagnose.
Exactly. Right.
So, like,
Right.
what are some of the um those signs that your partners, your families can be watching out for?
Oh, I think it's just if you're just feeling really, really bad, that's actually a sign that always gets me like red flag. Like I don't know exactly how to put my
Okay,
finger
okay.
on it.
Dr. Rankin, I'm
Hmm.
coming in for my post-birth appointment and
Hmm.
I just say I feel really crummy. Like,
Yes.
what follow-up questions are you going to ask to like
Sh-
find out?
sh-
Because how are you supposed to know how you're going to feel? Like post-birth feels crummy. I've done it 4 times. It feels crummy, but crummy and really crummy.
right. Right. It does, but I think there's also like a progression of things. I think for the most part, most women feel a little bit better, a little bit better, a little bit better. You're not
Okay.
like getting worse. So you want to see how you're feeling over time compared to your birth. And then you ask, well, what do you mean by crummy? Are you tired? Are you
Hmm.
not getting sleep? Are you having trouble moving around? Could this
All of the
be
above. So then, are you
depression?
just going to tell me to take a
Um,
nap?
yeah, it's really difficult to say,
Yeah.
like, I don't think this is like necessarily the best forum to play through that sort of scenario because every person is different. So if it's like, if you had high blood pressure during pregnancy or if you had any issues or difficulties with your birth, then I would be looking through that. We can't sit here and go through some sort of like standard
No, no,
scenario
but
that'll
it's
help
just
people.
we
Mhm.
keep just hearing these stories. Oh, we didn't see it coming, or hey, the doctor ignored her, and then all that does is perpetuate fear
I
that you're just gonna drop dead one day.
Yeah, sure. So I think the key is if you're still not feeling well, if you're feeling like you're not getting answers resolved to your satisfaction or you're not feeling better, then you need to be persistent and have someone who can advocate for you ideally as well. But persistence is probably key, and changing to someone else if what you're getting isn't satisfying what you need. That can be difficult. I'm not saying that that's necessarily an easy task, but if you feel like you're not getting better and you're not getting responses to what you need, then you have to be persistent until
So
you
it's the
get
same
the
as
responses you need.
before your birth. You can switch providers. You can switch providers after your birth,
Sure,
right?
absolutely. Hmm.
Wow,
Yeah,
I couldn't
absolutely.
imagine. So why do you think that then Black women are 3 to 4 times more likely to die after childbirth with childbirth related issues, even when socioeconomic status is included? Like,
It's racism. So,
so are they just being ignored? Like,
well, that it's that Black women are treated in multiple ways in different ways. Either they're ignored, their concerns are minimalized. So not even if they are addressed, even if they are acknowledged, they're not accepted to be at the same level. Things aren't acted on necessarily as quickly if they are being acted on. There are, of course, some underlying potentially health um, issue, whether we're more at risk for things like carrying extra weight or
mhm,
hypertension, but a lot of that factors into societal stresses as well. But
yeah,
the
for
the
sure.
bottom the and it's not it's not because of race. It's because of the way race influences the experience that someone has and what that
Got it.
lifetime of experiences does to them.
So I used to be a certified interpreter and I attended several births with deaf women, and it drove me crazy because I would see the cultural, just you would think deafness, they speak English natively, Black people, they speak English natively. You would think that we're all one big happy family, but there were nuances in the difference in the deaf culture and the hearing culture that as an interpreter in the hospital room was really hard to bridge.
Hmm.
And I would see women have less than ideal care as a deaf woman just because she was deaf. And I wouldn't have said it was like an ADA thing or discriminatory thing, but I feel like it was like a cultural mismatch. Like she couldn't get herself heard because the doctor couldn't understand her cultural framework. Do you think
Right.
that's part of it?
That's part of it, but I mean, I think it's just that we're conditioned in society in many ways to treat people a different way. I think one of the ways that I learned a lot about this is from when I had a birth photographer on the podcast, and she shared how she would have women who had very similar experiences or health things or concerns, and she would be at those different births, and one was a Black woman and one was a white woman, and it could be totally different experiences in the way that they were treated and the preconceived notions that the providers brought in about how they thought those people, the preconceived notions that they brought in, how that influenced people's care.
Fascinating. I'm a birth filmmaker that's my profession. So that would be an interesting documentary to explore. I'm sure people would want their footage put into a documentary without their permission, but
Right.
that is really, really interesting. So they can see the juxtaposition of these two circumstances. Wow. Okay, so is there anything else that you would say about like the right or the wrong way for you as an individual to birth, like how to navigate those choices just for yourself?
Other than there is no right or wrong way. It's really about whatever, getting in tune for the things that you want and are important to you, and being comfortable expressing that and advocating for that. Like I see both sides, where I have stories where women say, everybody in my family says I should just get an epidural. And I don't understand why they keep, they don't understand why I want to do an unmedicated birth. Or I hear the other side where everybody says I better not get an epidural. Like I better do an unmedicated birth.
Mm-hmm.
And there's like neither, a lot of the things focus around pain management, at least in the hospital. So just whatever you feel like you get in tune with the things that you want. Don't make decisions based on fear. Make decisions based on information. So inform yourself, get information, then make decisions. Don't make decisions based on fear is probably the biggest thing I would say.
That's amazing. I love that. Don't make decisions based on fear. I love it.
And there's a lot of things that are scary about birth because it's very much so an unknown. So, and we don't have the same sort of things in our culture and society where you're exposed to seeing what birth is actually like. So you don't know. What you see is on TV and, in movies, which is highly like not normal.
No.
So we don't have a lot of information, and it's not something that we talk about. So I get it. I'm not saying that there's anything wrong with feeling fear. That's a really normal response. It's just a matter of how you deal with that.
Yeah. Fear is normal, but I love it. Wow. Okay. So you mentioned it earlier in the podcast, but we always do it at the end too. How do people find you? Follow all the stuffs.
Oh, sure. So I am on Facebook and Instagram at Dr. Nicole Rankins, and my website is drnicolerankins.com. So that's my new website. That should be out within the next month or so.
Yeah.
So
So
drnicolerankins.com.
NRC coaching is what it is now.
Right now, NCR coaching. That's my initials, Nicole Calloway Rankins. So ncrcoaching.com is what it is now.
It'll be changed. Awesome. Probably by the time this releases. This has been so fascinating. Thank you so much.
Sure.
Really, really appreciate it. Very interesting.
No problem.
Please visit us at birthcircle.com, join our Facebook groups, or find us on Instagram and Pinterest. We hope you'll use our resources to support your birthing experience.